SERENA-6 was a trial that was novel in the sense that patients were being treated who had ER-positive metastatic disease, HER2 negative, and they were started on what we would think of as sort of the prototypical first-line therapy, a CDK4/6 inhibitor, an aromatase inhibitor, and patients were, over time, monitored. They had to be on therapy for at least 6 months without evidence of disease progression. And then they were monitored for the emergence of ESR1 mutations. And again, as I suggested, ESR1 mutations can occur as an early sign of endocrine resistance. And it may actually emerge before there's clinical evidence that the disease has changed. And once that happens, we know that it's inevitable that the patients will develop disease progression. The question that was being addressed in the SERENA-6 trial is, does it make any difference if, knowing that biologic thing is changing, that molecular thing is changing, if you intervene then before the metastatic disease was clinically apparent, would you impact on outcome? And by intervening, I'm referring to changing their therapy. So the SERENA-6 trial was designed in such a way that in those patients who'd been on therapy for 6 months without any evidence of clinical disease progression, and thereafter they were being monitored for ESR emergence, if that happened, you either stayed on your current therapy, which is the standard of care, because you wouldn't switch without clinical evidence of disease progression, or you made a switch to a different endocrine agent, in this case camizestrant, one of the newer SERDs that's being developed, and still continue with the CDK4/6 inhibitor. And the novelty, of course, is you're making a change in therapy with the hopes that that will impact on outcome. And what was found in the trial is that indeed the PFS, and there's a discussion about, is it really PFS1 because there wasn't clinical disease progression, but it appeared that the time until disease progression was markedly improved in patients who had an early switch based on the emergence of an ESR1 mutation. And that delta, the difference between the two groups, by anybody's measure, was clinically significant. It was, something like 8 months of an advantage. So I think it was clinically meaningful. I don't know how you interpret that data. I don't know if you have a sense that that is compelling enough as it sits right now, or are you waiting for something else?
So I think that's a really key question, right? As our clinical trial portfolio has become so crowded, and first, second, third, fourth line therapies can in fact affect survival, progression-free as well as overall survival, it becomes very difficult to judge one treatment switch at a time to really make an impact on the whole portfolio of things that are still ahead for that patient, right? So for me, I find that data extremely meaningful because I intuitively buy into the concept of emergence of resistance. And so, which is also part maybe of the design criticism for this clinical trial, because the control arm ultimately suggests that you're continuing, like you're saying, in a standard of care, which intuitively is inferior, because we do know from other clinical trials that patients who develop these ESR1 mutations who are treated with an aromatase inhibitor backbone have an inferior outcome, right? And so there is some sort of skepticism baked into that. But to your very well-raised point, if we didn't check for these emergent mutations, we would not have known that they're actually coming about.